Welcome to Season 5 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Joshua Sharfstein, Vice Dean for Public Health Practice and Community Engagement and a former health commissioner here in Baltimore, Maryland. Our goal with this podcast is to bring scientific evidence and experience to shed light on critical health issues. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hi, I'm Lindsay Smith Rogers, producer of Public Health on Call. Today, Stephanie Desmond talks to Dr. Sabra Klein, a biologist at Johns Hopkins who studies sex differences. They discuss the biological, social, and behavioral reasons why men are more likely to have worse COVID-19 outcomes than women. Let's listen.
Sabra Klein, thanks so much for joining me.
Thank you so much for inviting me again, Stephanie.
Today, I wanted to talk about, your area of expertise, which I know is in sex differences in general. But here we are talking 2 years into COVID, and I'm curious what we have learned about the differences in men and women and how the disease impacts them. So could you start with sort of telling us a little bit about, give us the landscape?
Okay, so the landscape is still that across diverse countries, including the United States, and including with variants of concern, we still see more men being hospitalized and dying from COVID-19. So that difference has remained the same over these 2 years. What we are also starting to see, though, as we're at, well into this, and we're starting to talk about long COVID, which its official term is post-acute sequelae of COVID, we're actually finding it's women who are more likely to have the symptoms of long COVID, including the brain fog, the fatigue, some of these really tough, nondescript, hard to identify and pinpoint a mechanism types of, long-term symptoms, even including the loss of smell and taste. And my group, as well as many others at Johns Hopkins, are really trying to mechanistically uncover, what's going on with long COVID and why it might be that women are more likely to have this. I think the other thing that has really come out during the pandemic, especially after vaccines were introduced, and, we're managing at a School of Public Health how to address vaccine hesitancy. And one of the more hesitant groups have been pregnant women, which, has been disappointing for me as a female, as someone who has been pregnant and knows the value of vaccination during pregnancy. And that hesitancy has really been a bit profound, despite the fact that there are ample data, and your listeners could even go to the CDC website to see a write-up of these data, that pregnant women are at greater risk of more severe outcomes from COVID. So they're more likely to be hospitalized. And their risk of having adverse outcomes to their pregnancy, including preterm delivery, is about 40%. They're at a 40% greater risk as compared to pregnant people who do not have COVID. So those are some pretty profound observations.
I also understand that men are more reluctant than women to get vaccinated.
This is so true. But what I'm finding interesting is there's not a lot, but what I hope is they will continue to explore the intersection of gender. So as you brought out, men being more hesitant, which is absolutely true. But in some respects, it's also been shown to intersect with race, where Black or African-American men in the United States are more hesitant about these vaccines.
So I guess I'm trying to figure out what's at play here. I guess you are as well.
Yes.
Is this a biological thing? Is it a social thing? Is it a behavioral thing? Like, how are we getting these disparities?
I love it. So, when we talk about men being more vaccine hesitant than women, or concerns that pregnant women have about vaccines, I would say that's much more, obviously social. It's doing the risk assessment, what literature you're reading, who you're interacting with, what your past experiences may have been, that all might feed into this. So I would describe those as gender differences. So whether, reporting of greater adverse events among women as compared to men is a reporting bias, meaning that, it's maybe a socially based difference that women may be more likely to report not feeling well. It might be more socially acceptable for women to report this. Or like when we talk about fever, this is being mediated by immune cells making proteins that contribute to development of fever. And they're making these proteins in response to something foreign like this vaccine antigen. And we do know that women tend to have greater inflammatory immune responses than do men. So whether that's biological, and chances are at the day's end, many years from now, when we're really evaluating all of the data that have come from this, we're probably going to learn that it's an intersection of both the social construct of gender as well as some of the biological determinants that define our sex differences.
Mm-hmm. It seems like a sort of a fascinating puzzle. And I'm wondering which parts of it you're focusing on right now.
As a biologist, I focus on the biological pieces of this puzzle. So, what we attempt to do as biologists is, look at what observations we can make from the bedside, from either COVID patients or from people who have been vaccinated with COVID vaccines. And then what we try to do is we try to translate this into animal models where we can get a bit more mechanistic and we can interrogate the immune response to better understand why it is that there are these differences and where these differences are occurring. So just as one example, when we talk about vaccines and observations that we and others are making, that for COVID vaccines, we do find that females mount greater responses to the vaccines, not only among young adults, but working with a gerontologist at Johns Hopkins, Sean Lang. We've been working with older aged people 75 years and older. And what your readers may be aware of, or your listeners, I should say, should be aware of, is that our immunity declines with age. And we're often concerned about our oldest aged people in our populations and how well they're responding to the vaccine so that, the vaccine can actually protect them. And what Sean and my data are showing us is that the age-associated decline that occurs in immunity following vaccination is much greater for males than females. We're not really seeing it in females. A female can be 75, a female can be 100 years old, and there is maintenance of a level of immunity that does not decline. Whereas as men age, that immunity is just declining. So again, we're making observations about some sex-specific effects of aging. It's only occurring, that age-associated decline, it's only occurring in men. So then we can go back to our animal models to try to understand at the level of the immune cells, what's going on with those cells? Why don't they perform as well? Why do they lose their ability to perform well with age? And why do we only see that in males and not females?
That's really fascinating. So tell me about, also, are women more able to protect themselves not more able to, but are more likely to protect themselves because of sort of social norms as well?
I love that question. So earlier during the pandemics, these were data that were published in 2020. There was a study that looked across diverse countries. I will say these were all high income countries, and showed that across these diverse countries, women were more accepting of non-pharmacological interventions during this pandemic than were men, whether that was masking, social distancing. Even pre-pandemic, we knew there were data that women wash their hands more often and more thoroughly even among healthcare workers, than do men. So I do think some of the social norms are to be more accepting of some of the behaviors that can promote, for lack of a better phrase, a healthier lifestyle, avoidance of infection. And maybe that goes back to in our society, women having more responsibilities associated with family, needing to stay well, needing to stay healthy. Do these things get passed down from one generation to the next? I think is very interesting. But we are seeing this actually across, some very diverse countries. But I do think it's important that the countries, I made that statement about high income countries, because I think in high income countries, you have situations where females are more likely to have equal access to healthcare and to other things that also contribute to keeping them well.
So where do you hope your research will lead you here?
Absolutely. So I think for me, two things. I'm joining you from a school of public health, and I hope my research starts to inform experimental design analyses and maybe policies about how we consider sex as a biological variable in epidemiological and clinical studies. I will note none of the pharmaceutical companies that produce these vaccines powered or analyzed or provided analyzed data to speak to differences between males and females. But I am starting, and I'm often a reviewer for papers that are now being submitted from these various companies with their post hoc analyses showing that females do in fact mount greater antibody responses to these vaccines, including the mRNA vaccines, than do males. So, I really hope that this type of work stops being left for those post hoc, we weren't really powered to do this analyses, and starts being incorporated into experimental design. From my biologist perspective, I really hope that one of the next times that maybe you and I have an opportunity to speak, I've really done the work necessary to identify those cell populations and those proteins that explain why it is that males suffer a worse outcome from COVID-19 and how it is that females mount greater immune responses to COVID-19 vaccines.
And once you're able to do that, will we be able to sort of fix the disparity here?
I hope so. I think in order to fix the disparity, we have to agree that research has to be conducted differently in order to address these disparities. And I think we're starting to see that movement in the biomedical sciences. I think that movement has been faster in the public health research domain, which is encouraging, but not as fast in biomedical research. So I think until biomedical research really starts to embrace concepts of personalized medicine and that one size may not fit all, I think until that happens, I'm just always going to be coming on, beating the drum, saying we need to do this. So I hope in my lifetime that happens. I don't know if it'll be by the next time that you and I speak, but I am hopeful for the future, and I am seeing change.
Sabra Klein, thanks so much for joining me.
Stephanie, thank you for having me. It's always a pleasure.
Public Health On Call is produced by Joshua Sharfstein, Lindsay Smith Rogers, and Stephanie Desmond. Audio production by Niall Owen McClusker, Matthew Martin, Spencer Greer, and Holly Cardinale, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media support from Grace Holz Fernandez. Thank you for listening.